To become a patient was a completely new experience for me, and had really become accustomed to being the doctor and not being the patient. I got exposed to really the upper echelon of heart surgery, even as a medical student.
Someone who showed me some of my first stitches, and I still remember some of the important cases. Working with a guy who's technically brilliant, it's something that we do remember.
Difficult to cure, but usually can be managed for years. By the time I needed treatment, I was out of training and was beginning my career, really, in congenital heart surgery.
So it's something that we're quite accustomed to dealing with. Almost every other transplant, almost like at least half of our patients, I think, were fibrotic, if not more.
I had sort of standard anatomy. I hadn't had surgery on my chest or heart or lungs before. The problem was all of the other medical issues I had, having recently had a recurrence of leukemia, having been in acute respiratory failure for a couple of months before, and lost a lot of weight and all of my strength, and to the point where I became bedridden. I had just become a very lousy candidate for any type of surgery, much less a major surgery like a lung transplant.
Dean was a sick guy, and he knows. He's done this for a while.
By my calculus, the likelihood of me surviving a lung transplant in that particular circumstance was really low. The lung transplant team at Houston Methodist accepted me for an evaluation. In my opinion, took a lot of courage.
We knew about the risks, and so did he. But most of that was, fortunately, medical risk. From a surgical standpoint, there was some surgical risk.
I mean, this is what surgeons do, is you weigh the risk of the procedure and the benefit that the patient might receive from the procedure. And it requires people like the lung transplant team here making tough decisions every day, every hour of every day.
He had a good donor. We're happy with it, but he did have a slightly unusual anatomic variant, which made kind of the bronchial anastomosis on the right side. It was different than something that we usually do.
Instead of the right upper lobe of the lung being aerated by the right mainstem bronchus, that bronchus came directly off the trachea, which really complicates doing a bilateral sequential transplant. I think a lot of surgeons probably would have turned the offer down or elected not to use the donor. And I think it took a lot of courage for the team to say, okay, we're going to do this.
And Dr. McKenzie's airways actually fit quite nicely with the tracheobronchus when we were able to cut it and shape it to how we needed to.
That they managed to pull it off successfully is just phenomenal. You know, I know they do this all the time, and I'm not the sickest patient they've ever taken care of, but I was really sick. I'm thankful that they chose to do what they did for me. If it weren't for Houston Methodist, I wouldn't be alive.